we see this sometimes in endurance athletes as a common phenomenon. And they may, like during college, have some stress fractures and they recover and they keep training. And these are people that are at risk for entering the age 30 and beyond with a lower peak. And therefore, if you decline from there, say at 1% per year, or at menopause 2% per year, they're going to be really high risk for osteopenia or osteoporosis early on. I mean, you could have low bone density at the age of 21 if you had really severe energy deficiency. And then you mentioned Depo-Provera. That is one of the contraceptives that does reduce bone density while you're on it. And there are studies that show that the bone density does rebound and return over time. It could take a couple of years, perhaps.
Osteoarthritis is something that is common to see as we get older, this kind of degeneration of our joints. When you're speaking to women in perimenopause and menopause, what are some of the common symptoms and concerns that women will express to you that kind of will lead you into thinking that's probably what they're dealing with, as opposed to inflammatory conditions that can also drive joint discomfort?
Well, one thing that brings women in typically around the age of 50 or maybe even earlier, mid 40s, is that they're seeing an acute increase in the frequency, severity, number of joints that are bothering them without any change in their activity level. They're like, I'm doing what I always do. I play tennis or pickleball, more common now, or I run, a few miles a few days a week, and I've done this for years and I've never had any joint pain. And all of a sudden they're having this new onset joint pain, again, with no change or real uptick in their activity. And many times they've seen multiple providers and they're frustrated because they have x-rays that don't really show anything. Like it might be a knee x-ray that shows maybe slight joint space narrowing, suggesting their cartilage is getting a little thinner maybe, but no spurs. They may have an MRI. For instance, I like to use the knee as an example because it's so common. And, there's no surgical intervention indicated, like they don't have a meniscus tear or anything like that, but why are my joints hurting? And these are not people with rheumatoid arthritis. In general, that's a different subset of people that have, an autoimmune condition that is truly an entirely systemic inflammatory condition. So I think when you kind of hear that story, you start to think, oh, maybe these are slightly increased levels of inflammation in the setting of declining estrogen. We know that women are more likely to have joint pain as they enter menopause, and the early Women's Health Initiative studies even, showed percentages as high as 77% of women presenting with joint pain, and impacts of, utilizing hormone therapy in terms of ameliorating that. So it's really that like kind of onset that's vague, no injury. I haven't changed my activity and everyone says there's nothing wrong. I would say is that picture that I hear.
Well, and it's so interesting because I think for so many of us as women, we are the caretakers to everyone. We are always prioritizing everyone else's needs. And I have so many women that have shared with me that they just minimize knee pain, ankle pain, hip pain in particular, shoulder pain, which I'm sure will
Hands,
probably
people complain about
hands,
hand pain. Yeah.
feet, all of these jointy things. And until they get to a point that maybe anti-inflammatories aren't really helpful, or they don't want to be taking those kind of chronically and habitually. And so when you're looking or speaking to these patients in particular, what are some of the kind of first line therapies that you like to help them kind of work through before they get to more expensive, more involved modalities of addressing joint pain?
Yeah. Well, one area I end up, discussing with my patients a lot is what else is going on with you. Like, first of all, like, are you having night sweats or hot flashes and disrupted sleep and, other things like, oh, I see you're on a new lipid medicine, or is your LDL creeping up? I mean, I'm an orthopedic surgeon, but I just kind of like to see what else is going on with them. And so sometimes they're obviously in a state of perimenopause or menopause and having those other more typical symptoms. And while we know joint pain and inflammation isn't an approved indication for hormone therapy, I do kind of like take the opportunity to often educate about, the bone health benefits of hormone therapy, these other things that might benefit. Like there is evidence from the early Women's Health Initiative studies showing that hormone therapy did diminish joint pain, and withdrawal from it then did, show a rebound. And so, I tell women, I'm like, if you're having other symptoms anyways, and you're going to see your women's health doctor and you're thinking about hormone therapy, your bone and joint health may be another reason you decide to do it. I don't prescribe those medications, but I want them to know that they may see benefit from that. On the other hand, like what else can they do short of, using steroid injections, or other types of injections? My favorite supplement to tell people to start to reduce joint inflammation is a curcumin supplement, which has lots of good data behind it. That data kind of comes from the early arthritic literature, like mild knee arthritis, but I see a lot of people get a lot of benefit from just adding a curcumin supplement, which is not hard to do and has other health benefits as an anti-inflammatory. Um, and then, if someone is showing up with an effusion, like extra joint fluid, that's going to cause, like, again, in the knee, you're going to get atrophy of your muscles, and you get into this bad cycle of weakness, worsening pain, more weakness, and we want to break that. I'll occasionally, offer someone to drain their knee and inject it. Those are people who usually already have a little bit of more like structural change on an X-ray or an MRI. And in general, I'll talk to people about trying to incorporate, dietary changes that make their diet likely, a little bit more anti-inflammatory. So I also think that collagen supplements are really helpful for people with knee pain, and also people who have a little bit of early arthritis. There are two basic types of collagen supplements for joint pain. One is hydrolyzed type 2 collagen. So if you're using, that's the type you're scooping and mixing into things. And if you're using one of those, there are different types that are offered. So certainly we want the hydrolyzed type 1 collagen for bone density, but you'd like to get some type 2 collagen in your supplement for joint pain. And then there's another type of collagen supplement that works by a very different mechanism, which is called, you'll see it on shelves in pharmacies, you'll see UC2, like a 40 milligram capsule. And that the UC stands for undenatured collagen. So this is undenatured type 2 collagen, not broken down into peptides like the hydrolyzed type. And people are always like, how would that work? It's like you can't absorb it. And that's true. It works by a different mechanism, some sort of like oral tolerance type mechanism where your GI tract is exposed to this, sort of recognizes this undenatured type 2 collagen. And then what the basic science studies show is that subsequent to that, your body essentially is breaking down less type 2 collagen. So we see less breakdown products of type 2 collagen, almost like an exposure to it results in less breakdown of it, if that makes sense. So patients who I have, I'm like, I just can't scoop that stuff and drink it and deal with the powder. I'm like, you might want to try just the UC2. That's pretty easy. So.
Well, I think it's nice to have options because there may be people who are occasionally using anti-inflammatory agents like Aleve or Motrin. They don't want to be taking them habitually, but understanding there
Right.
are so many supplements that can have benefits, reducing inflammation and then adding in the lifestyle piece. And I think for a lot of people, when we're talking about anti-inflammatory nutrition, which you and your colleague do a really beautiful job kind of discussing the value of lifestyle, which I think is so important and oftentimes left out of the conversation. When you're speaking to women in middle age, they probably unknowingly, a lot of the things that we think are benign and kind of innocuous in our diets suddenly become a little less benign. So I think about,
Mm.
for some people, it could be gluten or dairy or alcohol or sugar is a huge one. I'm
Fried
oftentimes,
foods.
yep,
Yes, saturated
fried,
fats, processed meats.
yep.
Yeah, I think a lot of people are, by the time I see them, they're kind of making some changes, but I cannot tell you how often a patient will say to me at the end of a visit where we've done complex surgical counseling. I mean, they're coming in for an orthopedic problem, like they need the rotator cuff repaired or something, and we're doing the consent form for surgery. And then I say, do you have any more questions? Because I always finish visits with that. And these are the things people ask me. What should I eat?
Oh,
What exercise should I do? And what supplements should I take? And so, I mean, it's crazy how many times someone literally asks me, what should I eat? I mean, people are just, they really want to know what can, they want to know what can reduce inflammation, and then on the other hand, people want to know what they can do to help their bone density. And so much of that comes from diet, your dietary choices and exercise. So it's a really common question, even in a surgical clinic. which is fascinating to me.
I think the fact that you're open-minded to kind of initiate that conversation, to ask them if they
Mm.
have additional questions, I get the sense that you're probably an incredibly kind, compassionate person, and therefore kind of
Sometimes behind in clinic for this reason, yes.
but your patients probably love you, but that kind and compassion piece allows them to feel like, okay, I can actually ask this physician this question because she's
Mm.
opened up the opportunity for that discussion. When you're
Yeah, they like to ask me about everything. I've had patients ask me to be their primary care doctor, which is hilarious because I'm an orthopedic surgeon,
you're
but
like, wait, 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 I'm your bone person. But thank you. I appreciate that vote of confidence.
yeah,
When
yeah.
you're doing an intake with patients, are there things about their past medical history or their exercise history that'll kind of tip you off? Is it the, growing older athletic population, the former collegiate level athlete? Are those the people that are perhaps coming to you a little earlier with joint problems because there's been a lot more wear and tear? And I think there's also that other subsect of the population of people that or obese or overweight, and they just have joint problems just because it becomes a biomechanics issue.
Oh yeah, there's a few subset of people that develop arthritis earlier than others. One is, yes, if you were like a former contact athlete or soccer player, basketball, things like that, anyone who's had trauma to their knee in their teen and 20 years, like a meniscus injury or an ACL tear, those people are more prone to post-traumatic arthritis, which is not just biomechanical, that's also inflammatory. And so those injuries sort of set a little clock that ticks for about 15 years, and then the arthritis starts to show up. And then certainly we have people who are, overweight, and obesity is also an inflammatory state. And we're now learning so much about arthritis in obese people. It is not, that's also a combined mechanical overload, like literally overloading the cartilage and weight-bearing joints, but they also have arthritis in non-weight-bearing joints. So that has more to do with the inflammatory metabolic state. And we see that weight loss can benefit joints that are, non-weight bearing and weight bearing. So it's not just about overload with those people. And then, of course, we have the perimenopausal women who are having an increased inflammatory state because of their dropping estrogen levels. So those are kind of like three groups of people that have inflammation, you know, as a source of their increased likelihood of joint pain. And then women in general, at age 50 are, 30% more likely than men at the same age to have arthritis, probably related to these hormonal mechanisms. And we don't see a similar impact of arthritis on men until they're like 80 years old. So unfortunately, the women are getting the short end of the stick again with bone density and arthritis. But yeah, those are, I would say, a few groups of people that present, earlier.
And with the advent of the GLP-1s, are you seeing improvement in these kind of patient populations if they're utilizing the drugs? I mean, I know there's different ways to
Mhm.
use them. Some people are microdosing that are perhaps not per se using them for weight loss predominantly, but that whole inflammatory reduction benefit, I
Yeah.
would imagine, would be significant and profound.
Yes. The effect of these medications on orthopedic conditions is fascinating and I think broader reaching than I think we learn more every day. But there are two populations where, like, anecdotally I see differences, and there are basic science, reasons behind this. But so I have a large population of women that also have breast cancer and are, estrogen blocking agents, aromatase inhibitors, and so they are going through that really powerful estrogen withdrawal, and those patients, they get frozen shoulder, they get joint pain, um and it's not, going away. I've had some of them who are also on GLP-1 medications who have noticed significant benefit in their joint pain. And then, of course, I have patients who are overweight utilizing these medications for weight loss. They're losing weight, which is benefiting their joints because of the increased mechanical load on the cartilage, that smooth gliding surface of the joint. But they're also having less joint inflammation. And there are studies showing that there are really like receptors for these medications that act on the lining of the joints that can then impact some of the inflammatory pathways that lead to cartilage breakdown. And interestingly, those medications also seem to upregulate osteocalcin production. And osteocalcin, helps with bone building, and to overly simplify, it's helps with, the mineralization of bone. But it also, goes on over to skeletal muscle and fat cells and the pancreas and helps with glucose control or insulin sensitivity, which brings down inflammation. So there's this, there are many pathways that these GLP-1 meds are acting on bone, bringing down inflammation, likely impacting joints. So I definitely see that in people that they're benefiting from the weight loss and the reduction in inflammation in terms of helping their joints. I don't think we really know all of the effects of these medications yet. So
Well, and it's so interesting because every opportunity I get to ask providers that are using them or working with patients that are on them already, I'm always curious about how each specialty is
mm,
able to view the benefits of the drugs themselves. And I think for a lot of individuals, I think so many people think about it just about weight loss, and I think there's so much more to these drugs, especially the second generation drugs with the GIP and the GLP-1 involvement. And how many people are just telling me they just don't have food cravings anymore, which then creates all these other profound benefits. Now let's
yeah.
pivot a little bit and
Yeah, I
talk
don't
about
prescribe those, but
right.
it's out
You're
of my realm of practice. But I'm always trying to understand, yeah, it just like hormone therapy, how it impacts my patients. And yeah, for many people, it's really helping their joints.
Yeah, I think that's a wonderful benefit. Let's talk a little bit about bones. I think that bones are oftentimes forgotten about until there's a fracture, there's a problem, there's pain
Mhm.
involvement, there's an injury. And I think that many individuals probably don't realize that we hit peak bone and muscle mass in our 20s and up to maybe age 30. And so
Mhm.
when you're talking to younger patients, people that might be on oral contraceptives or Depo-Provera,
Mhm.
and really looking at the research about how that can impact bone development over time, what are some of the things that you're looking for that might be red flags, not just in younger patients, but in your other patient populations of someone that probably never laid down good quality bone?
Right. So yes, that's true. We really do peak in our bone density by age 30. And so I want to be clear, that doesn't mean that after the age of 30, you can't work on your bone density. And it's not like doomsday if you didn't figure out you need to strength train and do impact training until you were 50. It's just that you do have this unique opportunity before the age of 30 to build that bone bank and, really increase your peak bone density. And there are a lot of things like that can happen before the age of 30 that might reduce your ability to do so. One of them is overtraining and underfueling, which was traditionally referred to as the female athlete triad in women with disordered eating. But you can have someone that's not like truly anorexic, for instance, but they're just chronically underfueled because they're overtraining. And men can also have energy deficiency. So we now call this, relative energy deficiency in sport. And so, girls who, started menstruating and then like lose their cycle or have like a really, really delayed onset because of the overtraining and underfueling. And for instance, we see this sometimes in endurance athletes as a common phenomenon. And they may, like during college, have some stress fractures and they recover and they keep training. And um, these are people that are at risk for entering the age 30 and beyond with a lower peak. And therefore, if you decline from there, say at 1% per year or at menopause 2% per year, they're going to be really high risk for osteopenia or osteoporosis early on. I mean, you could have low bone density at the age of 21 if you had really severe energy deficiency. And then you mentioned Depo-Provera. That is one of the contraceptives that does reduce bone density and while you're on it. And there are studies that show that the bone density does rebound and return over time. Could take a couple of years perhaps, but or maybe not for everyone. That drug concerns me when someone is taking it and then they have an injury in their reduced bone density state. I can't undo their injury in that state, and that's a real problem. So that's probably my least, and again, I'm an orthopedist, it's probably my least favorite contraceptive to see a teen or 20-year-old woman on in general. Obviously,
Yeah.
I didn't make that decision with that person. There may be a reason why that was chosen, but it does affect bone density, at least while they're on it.
Yeah, it's really interesting. I just finished writing a book talking about the microbiome changes that occur in perimenopause and menopause. And when I was doing a ton of research about oral contraceptives, Depo-Provera, it certainly was clear to me that in the literature, teens and young adults are the ones that are most susceptible to the impact of laying, not being able to lay down the same quality of
Hmm.
bone.
Right.
And I think, you know, I'm the first person to say if you need good contraception, you need good contraception, period.
Right.
Uh, with that being said, I think that there's a lot of maybe missed opportunities to help patients understand, like, just so you know, long term, if you're taking these drugs for a period of time, it can impact the quality of your bone. And when I was in my teen years, I wasn't worried about bone. I wasn't even thinking about bone. And I think that's how many, you know, teenagers and young adults are thinking. They're, you know, they're going about their busy lives and they're like, you know, menopause is 1,000 years away and I'm not even
Yeah.
thinking about
Although
that.
my teenage daughter just said to me, oh, my number one concern right now is menopause. It sounds awful
Oh,
because I think she hears me talking about my
yes.
patients. I'm like, it shouldn't be your number. She's like, the thing I most fear is menopause.
Oh, how funny. But you know what? I don't even think, but it's incredible though. Like our generation is having those conversations. I think
Mm.
that maybe I can only speak for my mother, but like my mother's sibling, I mean, no one talked about menopause. And so I think that it's wonderful that maybe teenagers even understand what that
Oh
concept
yeah. My
is.
teenage son, we go work out every week together at the gym and he's said, Mom, do you think your estrogen patch is making your joints feel better? Because I had started an estrogen
Wow,
patch in
amazing.
perimenopause and I'm like, yeah, actually, I think it is. But it's kind of funny. He brought it up as a conversation.
That's amazing. That's amazing. I mean, and I think it just goes to show I have all boys, all teen boys, and having conversations with them just to help them understand, you know,
Hmm.
your dad will go through andropause. I mean, he's in it, and I'm in menopause. And, you know, it's kind of like women get, and I tell them, it's kind of like women get shoved off a cliff. That's how dramatically the hormones
Mm-hmm.
fall, whereas men, it's a little more gradual and kinder. With that being said, I think that it speaks volumes that this generation is having those conversations with their parents, even if
Right.
they're fearful of what that is to come. So when we're talking about red, so this relative energy deficiency syndrome, I think that is certainly really important, and that kind of focuses in on this disordered eating, irregular menstrual cycles, and then also bone loss. But there are other things that can set us up for being at risk for osteoporosis, and I think this
Mm,
is worth mentioning because some of these things we have control over, and some of them we do
right.
not.
Yeah. Thyroid conditions are one that can impact bone turnover and the way bone is formed. Yeah. Medications, if you have a seizure disorder and you have to
Mhm.
take a seizure medication for a long period of time, those can contribute to, decreased bone density. Being if you have really bad reflux disease or get gastric ulcers and you need to be on proton pump inhibitors kind of chronically, that can lead to lower bone density. So yeah, there are some things, yeah, and that's how I like to describe them too. Some things that are under your control and some of them aren't, and it's just good to know if you have some of those risk factors. Like if you arrive at honestly even like 40 and you had any history of that sort of energy deficiency picture, now you're on a thyroid medication or maybe you've been on a proton pump inhibitor from your GERD, like you're someone that should be screened
Mhm.
with the DEXA scan much earlier than someone that doesn't have any of those conditions. This being said, I think the recommendation of waiting until 65 to be screened for
Crazy.
osteoporosis is way too late because I think women need the information about where they're at with their bone density around the time that they're making a decision about using hormone therapy or not, because I really think if women had that data, it would like inform their decision more about, do they want to use hormone therapy for prevention of osteoporosis? Like, what if they found out they're osteopenic or near that? I really think that would help. I think information helps people with decision making. I'm not saying every single person or woman needs to use hormone therapy, but it would be nice to know where you're at because if you take that DEXA scan test at the age of 65, you're not going to get started on hormone therapy that far beyond menopause. You'd like to do that within 10 years. So the test is like mistimed with the decision making for something that is preventative.
I agree. And I think that it's both inexpensive and important because
Right.
if it's run in a particular way, you can look at the not just the quality of your bone, but you can also look at the, fat-free mass. I mean, it gives you some degree of,
Yeah, your body
your body
composition.
composition, which I think
You
is so
can get
important.
information about the density within your lumbar spine versus your hip. And, and we know that like impact exercise is more likely to help you gain bone density in your hip, and strength training is more likely to help in the lumbar spine. Not, I mean, these are both good things to do, but it would be nice to like know the reason behind why you're doing things and what you really need to work on.
Well, and I think it makes it easier for patient buy-in. You're
Mm,
absolutely correct that, information allows us to make decisions that are fully informed. To your
right.
point about, if we're screening at 40 or 45, at least then women can be properly counseled. Like
Mhm.
these are the things that you need to be doing to help protect your bones. And I think for a lot of people, and I speak from, I have a lot of older female relatives and how many of them have fallen and fractured hips, and they're all sharp as tacks and still going even years past their original hip fracture. But I think for a lot of people, understanding that estrogen therapy can have huge therapeutic benefit for the
Mhm.
prevention and improvement of bone quality. And I think one of the statistics in your book, you talk about 75% of women will experience a fracture. That's quite significant.
And when you look at hip fractures, 3 out of 4 of them occur in women. And we know why. And I just think so many women don't understand that hormone therapy, that one of the actual approved indications for it is for prevention of osteoporosis. You
Correct.
would much rather prevent it than treat it. Because treating it, these medications, like the bisphosphonate class of medications, it helps you maintain and gain a little bit of bone density. If you're on those meds for a few years, you'll gain about 6% bone density, but it's a different kind of bone. It's not necessarily organized in exactly the same way that bone would be formed if you were just forming it from activity and with maintaining your estrogen levels. And there are some side effects of those medications, like some that are really concerning and rare, like jaw
Yeah.
osteonecrosis
Yes.
and heartburn, and some atypical fractures, like the hip fractures that happen below the level of the hip joint. Those can be associated with those medications. But the point is, you'd like to not get to the point that you need them at all by maintaining your bone density. And there are definitely major reductions in the risk for hip fractures and vertebral compression fractures, all the locations that people get, osteoporotic fractures. So I just think that most women don't think of hormone therapy as something that's preventative of osteoporosis and fractures. They think about it for hot flashes and night sweats and things that will theoretically pass, not the long-term, consequences that exist. So,
Well, and it's so interesting in my past life as a nurse in the ER of inner city Baltimore. I can't tell you how many compression fractures I saw in women, how many
mm,
hips had to be reduced, sometimes in the ED itself, or they went off for surgical intervention. And understanding that there's this whole generation of women that really,
mm,
for the most part, lost the opportunity to be on HRT post
right.
WHI. And so I'm so grateful that things are kind of the pendulum is starting to shift back a little bit where we're having conversations to help educate women so that they can then go to their physician, their nurse practitioner, their PA and have a conversation about the appropriateness of therapy. And the thing that I find so interesting is there are lots of things we can do about bone health that are not per se those drugs that have the side effects. Like
Mm.
I can't tell you how many of my patients were on bisphosphates, and they would say to me, "Oh, my dentist is now fearful to do dental surgery on me because
I know.
I'm on this
That's
drug."
that rare complication.
Yes.
Now, I do want to be clear, if you have osteoporosis, those medications will reduce risk of fracture. And there may be a time if you're diagnosed so far into the process that you're, more than negative 2.5 on your DEXA scan, like those are important medications to have, for instance. And so it's not that they're a never thing. It's just, yes, there are many things you can do to not end up in that place where you need them, but they are very important medications when we need them.
And the whole concept of sarcopenia and helping your patients understand that muscle loss begets frailty, frailty
Mm.
begets falls. do you find that most of your patients are open to the concept of strength training? I think many people viscerally, if
Mhm.
they haven't been strength training and they're 60, 70 years old, they're like, no way, I can't do it. Or do you find like people are more open and receptive to discussions around that type of exercise therapy? I think women as a whole seem to be very open to doing cardiovascular exercise and
Mhm.
less likely to be interested in strength training. I think that's shifting and changing.
I
But
do
that's,
think it's changing. And I talk to patients about that a lot. Again, like the common scenario is someone coming in with new onset knee pain and they can't run like they used to want to run, and that was their main form of activity was cardiovascular exercise and running. And also, to be clear, cardiovascular exercise is not bad. Like it's very good for our heart and our lungs. 150 minutes of cardiovascular exercise per week has been shown to help. It's one of the things that prevents dementia. So these are good things, but strength training is definitely beneficial when we can't necessarily. Yeah, I guess what I should say is people get to this point where they do kind of naturally kind of shift away from some of the higher impact cardiovascular exercise. And I am telling them, like, strength training would help you have less joint pain. But I take that opportunity to also tell them there are major metabolic benefits for you to strength training. Like you're going to have better glucose control. You're going to be less likely to fall. The pushing and pulling and tugging on your bones from the strength training stimulates greater bone density. So strength training, programs in women who have decreased bone density will improve bone density a little bit, a few% over the course of 6 to 8 months has been shown. And, I always take that opportunity. I always tell women who are having, struggling to do their usual cardio, like, this is a good time to think about the benefits of strength training. And I always tell them the other benefits relate to, their metabolic health and their bone density. So it's just, I think it is something that people are open to adding on and taking on if you give them a little education about the benefits of it, like long term, and give them a little instruction.
I think that's really key in helping people understand that you're not telling them not to walk or do
Mhm.
other forms of cardiovascular exercise, but you are encouraging them to get acquainted. And do you have resources or um, people that you like to refer individuals to, whether it's physical therapy, or do you have, personal trainers in your community that you refer out to? Because I find there's sometimes some hesitation because they'll hear from, leading experts, lift heavy, and people are like, well, wait a minute, I don't even know how to lift.
Yeah, you
Maybe
can't
I
just
start with
jump into
right,
that.
exactly,
Yeah.
body weight exercise, like
Yeah.
helping people, where are the resources that you typically will send your patients to? I know that your book is a great, fantastic resource. Obviously, we'll link it in the show notes. But as a starting point, if people they don't want to injure themselves, that's what I oftentimes will hear is I don't want to hurt myself. And we're like, that is not what we're saying. But it's important to kind of learn the basics. And maybe it is starting with body weight and then lighter weights and then working your way
Hmm.
up so that you're being challenged.
Yeah, I mean, I try to tell people just, and there are benefits so when you think about resistance training, strength training, there's like certainly the high intensity level where you're doing lower number of reps, higher weight, something at 80 or 85% of your one-time max. Most of my many patients, they don't even know what their one-time max is. That's just not even a thing that they know. And so I don't want them to start that heavy anyway, because I don't want them to, get tendonitis and things like that. But I usually kind of will tell people to think about an amount of weight that they can do where they could get through like 8 to 10 repetitions, where they could do the eighth one with still maintaining really good form, but it's pretty hard for them. And I think that's, and doing a few, 3 or 4 sets of that, 5 or 6 exercises, you're kind of like at that lower to medium intensity level. Hopefully not going to get hurt, but they can start with that. If they're coming to see me for knee pain, for instance, I'm going to definitely refer them to a physical therapist, because one of the great things physical therapy can do for people, or hip pain or ankle or whatever, or shoulder, with the joint that's giving them trouble, they can help them find ways to work around the joint pain and still strengthen. There are obviously multiple ways to strengthen your quads and your glutes. And there are some exercises that every time I do them, I irritate something. And I'm like, I don't do that. I don't do the knee extension machine because every time I do it, it bothers me. I do
Mhm.
my quads in different ways. But so I think physical therapy for someone who has a nagging joint situation is a great way to like kind of weave in like a way to strengthen certain muscle groups. I think personal trainers can be helpful. Um, there, there is a group of physicians around me that I have access to that I can refer people to that actually offers a program where they help people determine like what is their 80% max. Like, so that I think some people just don't know that baseline
Right.
and give them a little guidance. That's sort of like a functional medicine group near me. And so I think those are like great, things to offer to patients. And then I tell them, yeah, you can build up to heavier lifting, lower numbers. And I think it's people get overwhelmed. So if you think about like some key large muscle group exercises like squatting, deadlifting, and overhead press, just think about like large muscle groups that they can include is good. But I do think people need to start light and build up. And that was the concept in the Lift More trial, which is like a randomized prospective study of menopausal women with reduced bone density, is they took a little while to build them up to the high intensity strength training. They started out with lower intensity, higher reps, and then built their way up and included a little bit of impact. They did some like basically jumping chin-ups with the bar. And that program was shown to be very effective and people didn't get injured, but they took the time to ramp them up.
I think that's
And
really key.
I also think people just need to give themselves some grace. I mean, you can see like a lot of people on various platforms showing you how they do all this really hard stuff, really heavy. And if you get injured or an overuse injury doing those things, and then you're out from the strength training for months because now you have tendonitis of your rotator cuff that you can't get over, you're not even doing the low or the intermediate level. So I think it's okay if you figure out that there are certain maneuvers or joints that just don't tolerate the highest of intensity. It's better to still be doing some resistance training.
Yeah, some is better than none. And I love your kind of kind messaging around giving yourself grace because I
Right.
think social media is both a blessing and a curse because what
Right.
might work for you and I may not work for other people.
Mm.
And so I always say that I think it's very important that we honor our own bio individuality. Now, in terms of looking at stability and balance, which is super important, the whole concept of proprioception, where is your body in space and
Right.
time? How much balance work do you typically like? Let's just say we're giving a general recommendation. How much balance work do you think is really important for us as we're aging, especially if we're trying to avoid falls, tripping over things? Like I jokingly, I'm married to a former college athlete who calls himself, he's like, I have cat-like reflexes, and every once in a while he'll slip, like everyone does. And
Yeah.
sometimes it's graceful and sometimes it's not. But we have this ongoing joke of this is why we do yoga, this is why we do Pilates, just so that we are like remaining
Mm.
flexible, able to balance. And when you're talking to women of this age range, what are some of your recommended? How frequently should they be doing it?
Yeah, so I think balance is really important, also a little bit of agility. And I like to not, I think it's hard if you tell someone to carve out more time to do more things. So, like I love to just stand in a tree pose and I'll just, if I'm just waiting around for something, if I'm waiting in line somewhere, I'll just stand on one leg and switch to the other leg. But I honestly tell people, I tell my patients, like, while you're brushing your teeth, like, while you're doing your bottom teeth, stand on your right leg. When you switch to the top, switch to your left leg. If you're waiting for a pot of water to boil, practice standing on one leg. I mean, honestly, when you're just
Practical.
standing around, just practice. I don't think, and who knows how much time that gives someone to do that, but I just think the more we layer upon someone and minutes, like we're already saying you need 150 minutes of cardiovascular exercise, and we'd like you to strength train, 2 or 3 days a week. I think trying to just be practical about when you do that is good. Or I also tell people while if you're doing like biceps curls, stand on one leg, switch to the other, like just kind of build it in.
Well, I love that because I think about the amazing Dr. Peter Attia, who I think everyone respects and it appreciates his tenacity and his intellectual rigor. But if Peter Attia talks about how he does, 2 hours of zone 2 and then does all this lifting, I have patients that will come to me and they're like, I don't know
I have
where
a
to fit
job.
that in. Right.
Yeah.
Exactly. And I was like, just remember that what works for one may not work for all. And each one of us have differing commutes and times, just depending
Right.
on, where your kids are in time and space. You may have more or less time to be able to exercise.
And I also think we can't be so siloed
Yes.
about what different aspects of your medical, of your body. Like you for cardiovascular health, for dementia prevention, for bone and joint health. I can't say you should give up cardio. That's not good for your heart and lungs and perhaps your brain even. So, and if you look at like what are like for your cardiac longevity, you need some high intensity interval training, something like, a Norwegian 4x4. You need an endurance day. You need a few days of 30 minutes of something like zone 2, like where you're like a little bit breathy. So, I mean, I try to help my patients like not black box things that they need for other reasons. So I want them to keep that the cardio. And then you have to think too, like, does someone have a little arthritis and they're not, maybe they can't tolerate certain types of cardio. So maybe they can't like, um, speed walk a few miles because their knee swells or they can't run, so they can't get that kind of impact. So we're saying, okay, let's bike, let's swim, let's elliptical. But yeah, does that give you less benefit for your bone density? That's true. But or maybe jumping makes your knee swell. So we're going to do less of that, but we're going to try to incorporate the strength training. And so I don't think we can be so siloed and only think about just our one little part that we're helping someone with.
I think that's important. And I think it probably very reassuring for listeners who may be thinking like, I don't know how to fit one more thing into my lifestyle because of all the responsibilities that we have. A lot of questions came in around frozen shoulder, which I know that you
Mm.
are very familiarized with. Let's talk
Yeah.
about what it is. What are the things we can do to help prevent if we are
Mm.
prone to it? Because I think one of my male physician friends calls it, it's like the 50-year-old woman's shoulder.
50
Like
year
it's just,
shoulder,
yeah.
yes. Yeah, that's actually a common terminology in some cultures, Japanese and Asian, Chinese cultures. They have that really literally refer to frozen shoulder as 50-year shoulder, and they're like, my mom got it. Oh, they just people just expect to get it because it's so common. But yeah, so frozen shoulder is also known as adhesive capsulitis, traditionally referred to as idiopathic, meaning we don't know what causes it, but that's, idiopathic means, again, we just don't know what causes it. But this is a condition that mostly affects women between the age of 40 and 60. If a man gets frozen shoulder, it's almost always in the setting of diabetes,
Oh,
another inflammatory
interesting.
state, or in the setting of a little bit of early arthritis that's just kind of extra flared up. But women often get this in the absence of diabetes, in the absence of any arthritis. And it's this sort of, innocuous onset of shoulder pain, no injury, suddenly the shoulder is really painful, loss of range of motion. At first, it just hurts when you rotate your arm like to the side, like this end range, like you get to a point where you're like, ooh, I just can't go any farther. It hurts. Women will describe they can't fasten their bra, they can't shave their opposite armpit because reaching across the body requires mobility. So anything that is like sort of requiring like full range of motion is getting restricted. And after this initial inflammatory phase where it's painful and they're starting to lose range of motion, there's this frozen phase where it's very restricted, but the pain actually diminishes and it's not so painful anymore, but it's just there's restriction of motion. And then there's a thawing phase where the range of motion gradually mostly returns over time. And so it's considered self-limited, meaning if we do nothing, this is eventually going to resolve. But who wants to go through like 1 to 2 years of this process? And I think, I've done a lot of research on this topic. I work with our Duke Women's Health team a good deal on this. And, I can't tell you that hormone replacement makes you necessarily less likely to get it or ameliorates it. But there's a lot of basic science to suggest that, certainly there are estrogen receptors in the lining of the shoulder joint. There are animal studies showing that blocking the effect of estrogen increases the fibrosis or stiffening and inflammation of the joint. That, having the activation of those receptors ameliorates that. That there's a basic science study that shows that estrogen inhibits the fibroblast, which thicken and sort of scar down the lining of the shoulder joint. And then we've done some research on that we need more numbers on to really, attain significance, but, sort of trending towards more frozen shoulder in people not using hormone therapy. And we have a registry where we're like following people over time through Women's Health right now currently. But I really believe this is hormonally mediated. And the other sort of group of patients that suffer from this are breast cancer patients on aromatase inhibitor. So they're not getting the anti-inflammatory effect of estrogen on their shoulder joint, and they get frozen shoulder. So it can't possibly be idiopathic if this almost always affects women aged 40 to 60.
Well, and that was one of my questions was in your anecdotally in your clinical experience, because I know there's ongoing research, women on HRT, are you seeing less of them that are impacted by the frozen shoulder as opposed to, as you mentioned, you're working with these breast cancer cohorts who
Right,
are on medications to drive down any existing estrogen they have in their
right,
bodies. I was kind of leaning towards, well, it would make sense to me intellectually, but obviously, since you're working in orthopedics, you would know best. And I
right.
think for a lot of people that are listening, that are thinking about, I've got joint discomfort and I've noticed since I've been on my estrogen patch that I have less joint pain. I always like to mention that um, for me, I noticed I started getting a little bit of right knee pain as I was in early menopause, and going on estrogen completely took all of that away. And so I do think the power of the N of one, the power of looking at the improvements that you see, not just in overall symptoms, but in joint related complaints can be quite significant.
Well, and as only like 5% of women use menopausal hormone therapy. So when we do this research, it's actually very challenging because we have such low numbers of cases of people that get frozen shoulder on hormone therapy, and you already have a smaller subgroup. When you're doing statistics, it just makes you need a really large group. So yeah, so you're already dealing with a smaller population, and then within that small population, you have very small numbers of people getting a condition. And so it just takes time. But yeah, I mean, anecdotally, my own story, this is in a horrible form of irony. I developed adhesive capsulitis in my shoulder several months ago, and I knew what it was really, quickly, obviously, because I'm very aware of my body and I know exactly what adhesive capsulitis is. And I was in a little bit of a denial for probably a couple weeks, and then I just started losing motion. I was like, oh my gosh, I have a frozen shoulder. This could not be any more ironic. I'm a female orthopedic surgeon and I do research on this condition. And so I went and got a steroid injection in my glenohumeral joint done by one of my partners, because that is a magical cure for people. If you catch it within a few months, you can really stop the condition and reverse it and really make a big impact on someone's function, and not make them go through like 1 to 2 years of freezing and thawing.
Mhm.
And so I went and got that, but I also went to see my women's health doctor, who's also a woman who I do a lot of research with in women's health. And I just decided, and like, I had some other things like LDL creeping up and like random nights right here, there. Like, I don't want to bottom out. And I also don't want to get frozen shoulder on the other side. And so I went ahead and started some transdermal estrogen, and, I haven't needed another injection in my shoulder. So far I don't have the other. And I think I'm hyper aware of the basic science behind what estrogen does in joints. And for me, that was really like a no-brainer. Like, it was just one of the things happening. So not that this is about me, but for example, when you think about what's going on, I saw my LDL creeping up, I got the adhesive capsulitis, you know, the sleep stuff, it just made sense.
Yeah, I mean, I think for so many people, it's also reassuring to know that as a clinician, you were able to kind of put those pieces together for yourself and you've seen
Mm.
such significant improvement. So, ladies, if you're listening to this and you suspect you might be suffering from the beginning stages, please get your shoulder looked at or any knee
Oh yeah,
joint.
this is not something to sit on. I especially in conjunction with menopausal symptoms or perimenopausal symptoms, because it's so common. It's honestly like the number one cause of shoulder pain I see in that age group. And other things like rotator cuff tears can occur and things like that, just basic tendonitis. But it's so common. What happens is women tend to, as you said, like take care of everyone else, not themselves. And so I mean, I cannot believe how late people present sometimes. They'll come in with like no motion. And I'm just thinking, how have you lived like this for the last 6 months? So it's not a thing to like, I make sure maybe take an anti-inflammatory for a couple weeks and see if you get better, but don't feel silly going in to have it evaluated because you can really catch it early and stop it and you'll be so much better. But we see this all the time with women. They also tend to present later with like their knee arthritis. Like by the time they present to an orthopedic surgeon, it's, farther along than, so there's just this tendency to kind of present a little bit, later.
What are some of the common other types of like neck or knee issues that you see? Maybe things that are non-surgical but are inflammatory or problematic for women at this stage of life. And I'm thinking about things that, maybe you may evaluate the patient, they get referred for physical therapy, but more common things that you'll see, maybe not at the point where they need surgery, but kind of annoying, nagging, persistent
Yeah.
symptoms.
Tennis elbow, lateral epicondylitis, which I think people get once they have a shoulder problem. So once people's shoulders start hurting, they get like what I call T-Rex arms a little bit. Like they kind of, people don't want to move their shoulders, so they're doing everything down
Yeah.
here. And, then they get lateral epicondylitis, and that's hard to get rid of. And then they start to get like hand pain. And
Hmm.
so they'll kind of get like an involvement of the whole upper extremity. And then yeah, I think yeah, hip and knee pain are also common. Sometimes trochanteric bursitis, that like inflammation of the bursal sac on the side of the hip, that's usually addressable with physical therapy. And a good physical therapist is invaluable if you kind of have a nagging joint issue. I mean, they can really give you the best path forward with strengthening and how to be like kind of customized for your condition. And I think people sometimes don't have a lot of faith that physical therapy is going to be worth their time or worth the copay. But as an orthopedic surgeon, I would say like it, I cannot tell you how much I have learned about my own physical ailments from my physical therapist. So I would
No, they're
encourage
invaluable.
people. Yeah, they're very valuable. Yeah.
There was I was at an event last year and I tripped, like my sandal got caught on a tree root and I pitched myself forward. I didn't fracture anything, but I actually got quite a bad sprain in my wrist. And I went to the hand and wrist physical therapist who was amazing. And I think I went twice a week for 6 weeks. And every other woman that was my age or older had a fractured wrist that they were recovering from. They all had surgically repaired. And
Right.
so I kept saying to her, like, I don't want to complain, but oh my gosh, I can't believe how painful this was. And so
Yeah.
it became this thing where I said, if I had never believed in physical therapy before, which of course I did, I see the value, but personally, I think it's what got me back to a level of range of motion and
Mm,
functionality much faster than if I had kind of blown it off and, took anti-inflammatories for a couple weeks, which in and of itself, I didn't want to be doing, but actually needed to. In terms of bone building foods, let's kind of pivot and talk a little bit
mhm.
about what are
I want to
the,
just mention though, when you talk
yeah,
about breaking wrists,
yes.
before we get to food, the common areas, aside from compression fractures in the spine, distal radius fractures,
Hmm.
these happen to women before the proximal humerus and before the hip. So if you're a woman and you've had a distal radius fracture, you know,
Hmm.
if I were you, I would get a DEXA scan because we see these a little earlier than we see like the proximal humerus or the shoulder or the hip. But I kind of put those in the same group
And
of
I think they're so
likely
common.
related to diminished bone density. Yeah.
Yeah, they're very common. I think my mom, the year that I was pregnant with my youngest, so this is 2007, tripped and fell. She was still working full time and she had plates and pins. I mean, she came down in a way that it wasn't just a cast and be good. It was, you now need
Yeah. You gotta fix
surgery.
it.
Yep, because she had osteoporosis. And to your
Yeah.
point, if that's kind of the sequela, like that is the starting point, and then the, future events are that you're fracturing your hip, and we
Mm-hmm.
know that can be a poor prognostic indicator for morbidity and mortality. Now, I have several female family members that have broken both hips and they are sharp as tacks and they're still mobile, but I tell them that, this is just we need to take all the rugs out of your, I mean, we need to be
Oh
super
yeah.
conscientious about the things that we can do to protect you from those falls that seem so benign, but actually can be a sign that
Mm-hmm.
that frailty piece is becoming problematic.
Right. Yeah, I didn't mean to interrupt you, but yeah.
No, 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 no. I'm glad that you interjected that. I'm grateful that I did not fracture my
Right,
distal
that's good.
radius.
Yeah,
That was
you
my
probably have
greatest
good bone
concern.
density. Yeah.
Um, yes, thankfully mine is still intact. But in terms of, I think this is important because there are many foods that are great non-dairy calcium sources. I think there's a lot of habits that we think of as being benign that can impact bone health. And by that, I'm referring to beverages that I think would be important to kind of touch on because I don't
Mm.
think we talk about this enough.
Yeah, too much soda, not good. Too much alcohol, not good. Um, coffee is actually okay. You could have a couple of cups of coffee. Coffee, um, actually has a couple of substances that may help with bone density. But those substances can also raise your LDL a little bit. So, I actually filter my coffee for that reason. Well, I don't want my LDL down, but yeah, and then foods. I think that people always think all your calcium comes from milk, and milk is a good source of calcium, or dairy. Dairy has good bioavailability, but there are a lot of people who can't that don't do well with dairy. It's inflammatory for some people. And there are some plant-based sources of calcium that are really good. I mean, cruciferous vegetables in general, the same family that broccoli and cauliflower and those are good. My favorite example, and honestly, like one of my favorite foods to cook and incorporate in meals, and just I think is an unrecognized superfood, is bok choy,
Yes.
which has really highly bioavailable calcium. And if you do the math, if you have a cup of cooked bok choy, you're getting the same amount of calcium as you are from a cup of milk, which
Yeah, I
is,
love that.
yeah, which is, some people don't realize that. Oh, every trip to the grocery store, I buy bok choy. But and then, yeah, there's like misconceptions too. Like, a lot of people think, oh, I don't eat dairy, but I eat a lot of spinach and a lot of almonds. And I mean, to get enough calcium from almonds, you would have to eat
A lot.
like so many almonds. Like you would be gaining weight from the amount of almonds you would be eating. And spinach is not really highly bioavailable because it has a high oxalate content. So you actually you absorb very little calcium from spinach. So it's just interesting. I think it's not something that people think a lot about, that yes, your calcium doesn't all have to come from dairy. And then not all plant-based calcium is created equal. It just depends on the bioavailability of it. So, and
Well, and
we
I
try
think
to
it's a
outline that for people. I try to make things really simple for people.
no, you do a beautiful job. And I think it just goes to show you that we should be getting our nutrients from a variety of sources. And I find that a lot of women in particular are very sensitive to cow milk dairy as they're
Mm,
navigating perimenopause and menopause.
mm.
Maybe they tolerate goat or sheep's milk, cheese or milk or yogurt.
Yeah.
Cow milk dairy seems to be less well tolerated. And so I always like to find non dairy options so that people know that, just another reason to get more vegetables into your diet and being
Oh, yeah. And
conscientious
there's so
about
many
which
benefits to that.
ones.
And
And then
my co-author is a registered dietitian, and we're very integrated in our thought processes because we were both gymnasts,
I
and
read that.
we've known each other forever. And it was very seamless working with her on this book. And just I studied nutritional science as an undergraduate at Cornell, and it's always been an interest of mine. But I love like bringing together like sort of my orthopedic knowledge and her knowledge together, and just trying to make things really straightforward for people.
Well, and I think that's important because then it's actionable. I think when we make it complicated or we make it too nuanced, then people
Yeah,
feel like it's
actionable.
like, I don't even know where to start.
Right.
And so
Yeah.
your book does a really nice job of breaking the information down and making it very accessible. Now, before we kind of end our conversation today, I would love to know. I know you're a mom of five, so
Mm.
you're a superstar mom of five. Happy Mother's Day. It's the day after
Thank
Mother's
you.
Day.
Yes.
Um, what are the things that you do conscientiously as a mom and a middle-aged woman to support your muscle and bone health? Like, what are the things for you as an orthopedic surgeon are the highest priority?
Yeah, definitely dietary choices. I'm always thinking about like, yeah, am I getting enough calcium and vitamin D? Always trying to get, a variety of plant-based sources and some dairy. I do take a vitamin D supplement, 2,000 international units a day for both an anti-inflammatory component and bone health component. There's evidence that a supplement at that level helps reduce joint pain as well. And vitamin D has a multitude of benefits, even maybe related to dementia prevention, perhaps. But um, and then I take a magnesium supplement, 400 milligrams of magnesium glycinate. Magnesium kind of helps vitamin D help us absorb calcium. One of my patients said to me the other day, like, wait, I have to like eat enough calcium and I have to get vitamin D, and now I have to have something to help my vitamin D. I'm like, yeah.
Yes.
Now you can get magnesium through your diet, of course, but I think the magnesium supplement helps some with sleep as well. And actually, a lot of cardiologists will tell you for patients that have like random palpitations and they've had like an entirely like normal monitor, like they've not found it.
Magnesium. Yep.
It actually, they often recommend magnesium glycinate. So I think magnesium glycinate is great for various reasons. So I take that. And then in terms of bone density promoting activities, I definitely try to strength train 2 or 3 days a week. I am of the level, and I don't have significant injuries. Well, I did, but I've worked through them. I kind of tend to do a little bit of the heavier lifting, sort of the 4 sets of 6 to 8, or I drop down as I go up higher in weight, and sort of like 4 large muscle movements and then some smaller stuff. I like to incorporate some impact a few days a week. There's a great study that showed a few times a week, just doing about 30 jumps can help improve bone density, about 1% in your femoral neck region. So I like to do a little bit of impact activity. That would be like some sort of jumping, like I'll do box jumps or drop jumps, things like that. If you're someone who can't do jumping because it aggravates your knee, you can do pool-based jumping. That will help. You can do like a little bit of assisted jumping, like they did in the Lift More trial where they did jumping pull-ups. Doesn't have to be like full-on high impact. It doesn't have to be a lot. So yeah, those are the things that I'm doing for bone density: strength training, some jumping, make sure I get enough calcium. I do a vitamin D supplement. I do a magnesium supplement. And I'm just going to continue doing that, and definitely. And then when I do transition entirely to menopause, I will increase my dosing of my hormone therapy. But I'm intentionally not bottoming out because I just, I don't want to experience that. I'm kind of easing into my decline or buffering it.
Well, and I think that's really key is that, when I went through a little earlier than I had anticipated. And so I tell everyone that at that time, maybe, 5-ish, 6-ish years ago, it was not as proactive to start before you went into menopause. And so I'm always encouraging women, if your sleep is impacted,
Mm,
talk to your provider about progesterone. If you're having a
right.
lot of vasomotor symptoms and hot flashes and disruption in sleep, as well as genitourinary symptoms, which it's not a question of if, but when. We will all experience that if we're not on some type of replacement, have
Right.
that conversation sooner rather than later.
And the other thing that I think a lot of women don't think about, which I also use, is 5 grams of creatine a day. Um,
Creatine monohydrate is like a
yeah.
foundational supplement. It's something that I think
Yeah,
is
I mean
really
it,
important.
there seems to be some cognitive benefits, certainly maintaining and improving muscle mass, which has a secondary effect on your bone density. I don't think that creatine monohydrate in and of itself, if you just took it and did no strength training, would help with your bone density, but it then helps you with the benefits of strength training. And so I think that is another thing in your armamentarium to help with bone density. It's indirect, but I think it helps. And you notice I talk about dementia a lot. I think, dementia is certainly part of frailty, and or just, exercise, things that I'm aware of, exercise and vitamin D supplementation and likely hormone therapy, and, possibly creatine. These may be ways to kind of help us maintain better cognition. So I try not to be too siloed, even though I am an orthopedic surgeon. My main priority when I'm treating someone is to help them with their bone and joint problem, but all these things are so connected and overlap.
Well, and I think, I mean, it's just being thoughtful. I can tell that
Yeah.
you're a very thoughtful provider. And it's interesting. I think the preliminary research is suggesting to cross the blood brain barrier, women need a little bit more. So 5 grams a day is like a great starting point. If you're looking at bone and brain, you need anywhere from 8 to 10 grams. And that was based on conversations with a creatine researcher. And he was saying, as they were, you need a little bit more to get across that blood brain barrier. But I agree with you, even helping in some instances with sleep architecture. We have patients that are reporting significant improvement in sleep quality by
Yeah.
virtue of taking higher doses. And I also use it for jet lag. Just as an aside, I
Oh,
travel quite a
interesting.
bit, and it's been
Yeah.
really helpful. I just increase the dose, pre and during and afterwards, and I tend to have a lot less jet lag.
Yes, maybe I should increase my dose a little bit. Yeah.
Yeah. That's been I usually double it around travel, and that helps a lot because otherwise I'm struggling, especially when I go west as opposed to east. Well, Dr. Wittstein, it's been such a pleasure connecting with you today. Please let listeners know how to get access to your new book, The Complete Bone and Joint Health Plan, that you co authored with your friend, Sydney, who's a registered dietitian. Follow you on social media, or if they're in the North Carolina area and they'd like to work with you, you're based out of Duke
Yeah.
University.
Yeah, I work at Duke. Sydney actually offers amazing high intensity sort of strength and core circuit classes online, which are amazing. I do them. I do hers every Sunday. But yeah, so yeah, or you can get the book on Barnes and Nobles or Amazon online or any really bookstore that you shop at. They can get that for you. And yeah, I have an Instagram page, which is just Jocelyn_Wittstein_MD, where I honestly just sort of try to offer people useful tidbits of information that relate to bone and joint health primarily, and how that intersects with women's health oftentimes.
Well, thank you for the work that you do, and thank you for the conversation today. Hey, if you like this video, you guys are going to love this video, and I'll see you there.
We make almost all of our fat cells during childhood and puberty. And then once we finish puberty, we're done. That number of fat cells, in most people, there are some people who are an exception to this, and that's about 15% of people who are in the obese category. But most people reach a limit, and that's their fat cell number essentially for adulthood.